mu yi shi saboda muna son ƙasarmu ta ci gaba.
Today marks a turning point for the health of our people. Through our partnership with India, the Alliance of Sahel States will receive 50 million life-saving vaccines under a historic $1 billion pact. This is not just a contract, it is a promise to protect our children, strengthen our hospitals, and build a healthier future for Niger, Mali, and Burkina Faso together.
The heat inside the small clinic is heavy, almost alive. Outside, the sun beats down on the red Sahel dust. Inside, mothers hold their children close, some restless, others listless from fever. The nurse, her face lined with both exhaustion and determination, opens a small cardboard box, inside tiny glass vials, on the label, made. In India, the room stirs. For months, this village in Burkina Faso had been waiting, watching measles spread from home to home, fearing the cough that might take their youngest. But today, something has shifted. A shipment has arrived. Not just for this clinic but for hundreds across the Sahel. This is no small donation. It is part of a $1 billion agreement, one that promises 50 million Indian-made vaccine doses to the Alliance of Sahel States, known as the AES, a pact that could rewrite the future. For Mali, Niger, and Burkina Faso. But how did this unlikely partnership between the world's largest vaccine producer and a newly formed African alliance come to life? And more importantly, can it actually work, in a region where conflict, deserts, and politics conspire against it? The answers aren't simple, and before we understand the hope in this vial, we have to face the harsh reality it's meant to fight. In the heart of the Sahel, the fight for health is a fight against time. Across Mali, Niger, and Burkina Faso, millions of children have never received a single vaccine. The numbers are stark. Up to 33% of children in Chad and 22% in Mali remain zero dose, meaning they've never been immunized against diseases most of the world no longer fears. Here, measles is not a distant memory, it's a seasonal threat. Polio, thought to be nearly eradicated, has resurfaced in isolated outbreaks. Malaria claims lives every rainy season. And when clinics run out of vaccines, hope runs out too. Why? Conflict has fractured roads and destroyed clinics. Armed groups control entire regions, making medical outreach dangerous. For some mothers, reaching a vaccination post means walking for days, crossing areas where the sound of gunfire is common. Add to this the geography. Vast deserts, villages separated by hundreds of kilometers of sand, temperatures that make refrigeration a challenge, and seasonal floods that wash away dirt roads. And yet, despite these challenges, health workers push on, carrying coolers on motorbikes, boats, even donkeys. They improvise cold chains using solar-powered fridges. They keep lists of children due for shots, tracking them across migration routes and conflict zones. But resources are thin. The vaccines simply aren't enough. This is the backdrop against which the AES decided to act, not waiting for traditional aid channels, but striking a direct deal, a decision rooted not just in public health, but in sovereignty. Because for the Alliance of Sahel States, health security is national security, and their search for a partner would take them thousands of miles east to the pharmaceutical. India is no stranger to the global vaccine stage, often called the pharmacy of the world. The country produces over 60% of global vaccine supply. From polio to COVID-19, Indian factories have shipped billions of doses across continents. But India's vaccine mission isn't just business, it's diplomacy. During the COVID-19 pandemic, under its Vaccine Maitri initiative, India sent life-saving doses to more than 90 countries, often before wealthier nations stepped up. For the AES, the choice was clear. They needed a partner with scale, speed, and proven expertise. India had all three. Negotiations moved quickly. The deal, valued at $1 billion, would see India supply 50 million doses of measles, polio, and other essential childhood vaccines, along with cold chain technology and training for local health workers. This wasn't just a purchase, it was a partnership. Indian medical teams would work alongside AES ministries to design delivery strategies suited to the Sahel's unique terrain. For India, it was a chance to deepen ties in a region increasingly charting its own course, breaking away from traditional Western and Francophone spheres of influence. For AES, it was an opportunity to control their own health destiny, without strings attached. The announcement was made in Niamey, Niger's capital. Leaders from Mali, Burkina Faso, and Niger stood alongside Indian diplomats. Cameras flashed, speeches were given, words like solidarity and self-reliance echoed through the room. It was historic. But in the Sahel, history is one thing. Delivering those vaccines is another. The AES was born in crisis. On September 16, 2023, the leaders of Mali, Niger, and Burkina Faso signed a mutual defense pact, marking their exit from ECOWAS and their rejection of external political pressure. The alliance's message was clear: sovereignty first. They would decide their own security, their own trade, and now, their own health priorities. Health had been a low-profile issue compared to security and politics, but repeated measles outbreaks and rising maternal mortality pushed it to the forefront. The leaders realized that without a healthy population, no amount of political autonomy could be sustained. The vaccine deal with India fit perfectly into this vision. It was more than just disease prevention, it was a statement. We can negotiate our own international partnerships on our own terms. This spirit of independence is also visible in other AES moves, like introducing biometric passports to strengthen internal mobility and exploring joint agricultural programs to cut food imports. The Health Pact marked the first time AES countries had collectively negotiated a medical supply agreement. It was also a test. Could their young alliance handle the operational complexity of a project this size? The stakes were high, and the challenges were only just beginning. In the world of public health, getting vaccines from a factory to a child's arm is known as the last mile challenge. In the Sahel, that last mile can feel like a marathon through fire. The 50 million doses would arrive at ports in West Africa, some in Senegal, others in Côte d'Ivoire. From there, refrigerated trucks would carry them across hundreds of kilometers of open desert, through checkpoints, and sometimes into conflict zones. Maintaining the cold chain, keeping vaccines between 2C and 8C, is a constant battle. In areas without electricity, solar-powered fridges become lifelines. But spare parts are rare, and breakdowns can ruin entire shipments. Then there's security. Armed groups often control rural roads, sometimes demanding taxes from convoys. Health teams have to plan routes like military operations, coordinating with local communities for safe passage. Despite the obstacles, AES and Indian planners have laid out an ambitious schedule. All 50 million doses delivered within 18 months. It will require not just trucks and fridges, but trust between governments, trust from communities, and trust in the partnership itself. This pact isn't happening in a vacuum. It's unfolding at a time when Africa is becoming a key arena for global influence. For decades, France held significant sway over the Sahel. China has invested heavily in infrastructure. The US has focused on counterterrorism. Now India is stepping in, not with troops or loans, but with vaccines. This is soft power at its most human. By protecting children, India earns goodwill that no speech could match. It also strengthens trade ties, opening doors for future collaboration in energy, agriculture, and technology. For AES, the deal is a diplomatic win. It shows they can secure large-scale international agreements without going through regional blocs or former colonial powers. It also signals to other African states that alternative alliances are possible. In a small Nigerian village, Aka cradles her 9-month-old son. For weeks, she feared the rash spreading in the community was measles. But today, a mobile clinic arrived, its cooler filled with Indian-made vials. Her son received his first vaccine. She smiles, relief softening her face. In Mali, Nurse Fatoumata rides a motorbike across dusty plains, a small solar-powered fridge strapped to the back. For years, she's watched children die from preventable diseases. Now, she feels like she's part of something bigger, a continental shift. These stories aren't statistics. They are the human proof of a billion-dollar promise. Back in the Burkina Faso clinic, the day is almost over. The nurse packs the last empty vials into a bag for disposal. Outside, the mothers head home, some carrying children who will sleep easier tonight. It's just one day, in one village, but multiplied across hundreds of clinics, in 3 nations, it becomes something bigger, a quiet revolution in health. The $1 billion vaccine pact between India and the AES may not solve every problem in the Sahel, but it marks a turning point. A moment when sovereignty wasn't just about borders or armies, it was about the right to protect your own people. And in the Sahel, that protection now comes, vial by vial.